So this is a video of laparoscopic Heller's cardiomyotomy recurrence managed laparoscopically. That is, redo laparoscopic Heller's myotomy was done. So you can see the dilated tortuous esophagus in CT. It's more tortuous on the right side. It was confirmed with barium swallow, and in delayed picture again, it is a stasis of barium is there. And manometry is also confirmed. So this is the standard 5 ports, one supraumbilical 10 mm camera on 4 5 mm working port. I stand between the leg, monitor in the head end of the patient, it's reverse Tunnelberg position, and my team. So with the liver epigastric port, liver is retracted, left lobe, you can see the migrated stomach into the hiatus. So this is the recurrence is one is dysphagia is there. Again, patient had a hiatus hernia with the stomach as a content. So I started as usual from the left side. I released the adhesions of the liver from the previously dissected area. So that is considered very important. And this case, I could see the free lying stomach inside. So I am trying to take out the stomach. That is a migrated wrap basically. You can see the suture. So that is a migrated wrap. So all the adhesions from the wrap to the crus is being lysed with the harmonic scalpel, and we have to be careful. We should not injure the vagus now. So already dissected area is there, and laparoscopic cardiomyotomy is done. So the esophagus, the anterior surface of the esophagus, only the mucosa will be there. Muscle will be divided. So I have to be careful when I give traction and then do the anterior dissection on the esophagus. So these are the momentum adhesions to the migrated stomach is released. So these are adhesions to the crus. There is a left pillar of right crus. Once you find the sac, we have to take out the complete sacs. This patient, you can see the sac going inside the hiatus. So I didn't continue there. I come on this side, lateral side. So I'm started releasing the liver surface from the dissected previous site. So you have to give nice traction, identify the structures and divide, and do it very patiently, and keep gauze piece. No, there should not be any bleeding. And here the identification of structure is considered prime important. And now you can see I did some anterior dissection. I have to be very careful. My instrument should not injure the esophagus. That is only the sac I am dividing now. See, you can see the sac is going. You have to be careful. That is the esophagus. I am dissecting laterally so that the lateral curve will become straightened when you are taking out the sac. See, now I push the pleura. The sac is being coming out now. So without removal of the sac, mobilization will not be completed. That is the excision of. I try to excise the sac. When you're doing a sac excision, you have to concentrate two things. One thing is the vagus nerve, anterior vagus nerve. Second thing is the esophagus wall. We should not injure. Now you can see the entire esophagus is coming out. Once the sac is coming out, the lower esophagus has come out. I'm just checking the anterior vagus. You can able to appreciate the anterior vagus. Now you can see the hiatus inside. No, inside is completely mobilized. The left side esophagus has become straight now. So I excise the sac completely. So that considered very important in paraesophageal hernia. So this is also almost same paraesophageal hernia. I excise the sac. So now you can see the wrap with the suture. It looks like a polyester suture, ethibond suture. So I'm dividing the suture. I'm basically I'm disrupting there is a division. I'm doing a division of wrap. We should not injure the gastric wall. That is also very important. If it is mild injury, mild any injury, you can suture, but our aim is to not to injure any structure. You can see now, with the left hand I dissected, I confirm it's only the fibrous tissue, then I divided. Again, I am coming on this side. Can you see this type of tissue is there? I will divide, otherwise I won't divide. Slowly I am going on the right lateral side of esophagus, and here some thick tissue is there. It may be fundus, and here again I went up little bit up. See, that is the pleura. I could see the pleura. This harmonic HD, what I am using is a harmonic HD. The lower blade is a non-sticky lower blade, and it's a little bit sharp and curved tip. I feel is very useful in this type of fine dissection. You can see, very small tissue also I am holding, and then I am dividing it, and then I am dissecting like this. So it is regular, compare with regular harmonic, I feel it is very much useful. And then the sealing capacity is also more compared with the regular harmonic. So that is the vagus now, anterior vagus now. It's a little bit, looks a little thicker. So I can divide that fascia. So again confirm and then divide. So any fascia we are dividing, confirm and then divide. So that is very considered very important. Even though if you are confident, check once and then divide the tissue. So I want to see the posterior vagus now. I started lateral dissection. You can say I divided some suture. Maybe fundus of stomach, posterior toupee, they fixed here with the crus, posterior fundus, to prevent the transmigration. But this case, that's not worked up. The entire trap is migrated inside the hiatus. You can see, I am dissecting with the Maryland dissector. Identify the structure. If it is a fibrous band-like structure, I am dividing it. That looked like a lymph node. Again, I am not trying to take out the node. My aim is to uh, straighten the fundus. All the attachment, the suture to be removed, and then the fundus wrap to be disrupted completely. Then I can go for a myotomy. You can see still some suture is there. See, that suture is also I am going to divide. So many suture are there, but that not solves the problem. That means it is not a blame of suture, it is a technique, blame of the technique. Even if your not technique is not good, you apply so many suture, again this type of complication can happen. So it should be perfect suture at perfect site. Now you see the fundus is going behind the esophagus, fundal wrap is going behind the esophagus. Again the suture is there, so many sutures. Usually even in two-pay fundoplication, 7 suture, 3 on right side divided esophageal wall with the fundus, 3 on left side esophageal wall with fundus, and 1 for fundal wrap to crest, only 7 suture. So now again I am coming this side because the esophagus fundus wrap is going on, going behind the esophagus. So that is the caudate lobe. From the right crest I am separating the caudate lobe. You can see again some suture is there, I am dividing the suture. So chronic case, a lot of fibrous adhesions. Again, some suture is there. You can able to appreciate all polyester sutures. So again, you can see the fundus. So I cannot divide because I should not injure the fundus. I should not. So that's why I'm dissecting only the fibrous structure covering the fundus of stomach I am dividing. That fundus is adherent to the crus, right pillar of right crus. Again I am dissecting. I couldn't see the edge of the fundus. If I see the edge of the fundus, I can divide, so I am not able to see. Here also we have to be careful. Anterior dissection, only the mucosa will be there. Now is the lateral side. I am going on this side. See again, you can able to see the left crus, left pillar of right crus, otherwise called left pillar of right crus. Again some attachment is there. I am dividing all the fibrous attachment. See, that is the post vagus. You can able to see the post vagus. Second fundus is coming. Again you can see the suture. So many sutures done. So I am dissecting. I want to see the edge of the fundus. Then only I can divide. I don't want to divide blindly. So that will make a serosal tear or injury. So I don't want that. So when you're doing any redo surgery, you have to be very careful. You have to dissect very patiently. Identify the structure. The meticulous dissection is required. And this should be a definitive surgery. The patient should not have any problem after this surgery. You have to keep that in mind. Any surgery you are doing second time, or if some first time some problem happens, complication, you are correcting it. So you have to take more preoperative, take more time for preoperative decision making, and discuss with your colleague and do some investigations. Any extra investigations, no problem. And then once you are decided for surgery, that should be a definitive surgery. There should not be any problem after that surgery. So like that, keep posted in the morning time. Don't keep other cases, and that day any redo surgery, don't keep any other cases. So your mind should be free, and there should not be occupied mind, and there should not be any disturbance from other stops. That so next case when to be shifted, can we shift that left case, like that should not be inquired. That is a post vagus. There should not be inquiry like this. So your mind should be free. Discuss with the team, even staff nurse, first assistant, camera assistant, you discuss, then proceed. That is called culture of safety. Your team should have should so that is again post vagus I am marking, because it should not be injured. That's why I am marking repeatedly. Your team should accept that your decision is correct, what you dissected is correct. Everyone is accepted means then you can come with confident, they do confidently. So that is called culture of safety. So in redo surgery, all those things are very important. So again, I'm seeing on, you can see, I'm seeing left side behind the esophagus, and then coming on the right side on the lateral side of esophagus. I want to see the edge of the end of the fundus, but I couldn't see. So here, I don't know why the previous surgeon dissected so much on the lesser curvature side. So you can see the big window in the lesser curvature. Again, I'm seeing on posteriorly, again the stomach wall is going down. I'm not seeing the edge of the stomach wall. So I'm not dividing any structure now here. So I thought, okay, this has to be divided. Then only I can say, again I am coming from this side. So the right crus and this attachment to be divided. Then only I can able to see the edge of the fundus. You can see the dissector, usefulness of the curved dissector. This cannot be done with the harmonic. So I am dissecting. I could see fundus wall and then fibrous tissue adhesions. Can you see the fundus wall? Yeah, it is very clearly seen, white color. So that is the crus and fundus. Now you can see the fundus, edge of the fundus, and then this is the fibrous adhesions to the crus. Even though it's clearly seen, again I am dissecting that area. Now you can see that is the edge. Again I am dissecting, confirm, stomach is pushed down, then I am dividing. So, I do not want to even a small serosal tear, because we are pulling time now, we are pulling, it will be stretched. It look like a band. If you divide that, fibrous tissue or band, if you divide means it will be hole in the stomach. So, now the small attachment is there, you can able to see fundus stomach wall and the fibrous attachment. So, it is completely divided. I am checking on that side. Now, you can see the post vagus, very thick post vagus, and again I am started dissecting in the median arcuate ligament site, both right pillar and left pillar as meeting point. So, it looks like a vessel, a post-gastric artery is going to the fundus. So, I do not want to divide the artery, always blood supply is better. So, again I am seeing this side. So, that is from inferior phrenic vessel, it is one branch is going to the fundus of the cell, that is called post-gastric artery. So, again you can see the inferior gastric, it is not inferior, it is a splenic, from splenic it is coming, the artery is going to the upper pole of spleen. Can you see it is going to the upper pole of spleen. So, that is the post-gastric artery from the splenic artery. Now, you can see the vagus is full thick vagus, that is the anterior vagus, that is the lymph node. So, now I have to straighten the esophagus on the right side. Left side is already straightened by excising the sac, that is the area the fundus gone inside. So, now I have to dissect the esophagus right side, right lateral side I have to dissect. I have to be very careful because the myotomy site, I should not injure any the esophagus wall or mucosa. But if I do myotomy without straightening, again the function will not improve. So, that is why tortuous esophagus dilated is not a problem. Up to 6 centimeter we can go with the myotomy, horizontal centimeter 6 centimeter, but only thing the tortuosity should be straightened. Now, you can see the pleura, I am separating the pleura from the esophagus. Still it is not separated fully. Now, you can see the pleura is going away from the esophagus. So, now you can see it is straight. So, it is done anteriorly and right lateral side, already left side is done by excising the sac. It is a dilated esophagus, there is no doubt in that. So, now I am coming for myotomy. You can see when you are doing myotomy, I am not giving traction with the umbilical cotton tape, and I am not tying the cotton tape around the OG junction. In fundoplication, I used to tie it. Here I am using the cotton tape for only traction. And you can see the anatomy is very clear now. That is the mucosa of the esophagus, and that is the OG junction area muscle. So, that is the muscle is there in the OG junction, that is the undivided muscle at OG junction. So, that is the OG junction, and I have to come down around 3 centimeter. Here normally 2 centimeter in Redo Hellers, it is called extended myotomy on gastric side. So, 3 centimeter myotomy to be done on gastric side. Just I am marking up to what level I have to do the gastric myotomy, just I am marking. I used to start myotomy just 1 or 2 centimeter above the level of OG junction. This case already myotomy done in esophagus, it is very clearly seen. So, I started myotomy trying to start at OG junction level. Just I am marking up to what level I have to come. Say I am marking with the cautery. And usually I do perioperative endoscopy in all redo cases. There has not been any injury. You can see I started myotomy from the stomach side, gastric side. I am not start from esophagus because already esophagus is done, and we don't know up to what level we have to go. So that's why if you start from below, if you go up, and all the myotomy divided, the mucosa to mucosa is meet, that means that I'll stop the division. So that is the idea. So I'm not starting from above, I'm starting from below upwards. All other video if you see, I start the myotomy from esophagus, OG junction, and then stomach. Here stomach, OG junction. Now you can see, mucosa. It's already mucosa is very clearly seen on the esophagus side. Only the lower esophagus and the OG junction, some fiber is there. So up to that level, see, that is the divided edge. That is the blue color is the esophageal mucosa, and pink color is the undivided muscle. And the stomach was inside the hiatus for a long time. So because of the compression with the other body of the stomach, so that area is little bit fibrosed, and I'm not able to get the muscle clearly like a normal case. So that's why I'm doing it very slowly, fiber by fiber and layer by layer. Always myotomy, I use two Maryland forceps, both hand, right and left hand, and cautery will be on the right hand. I thought I have done the myotomy. I don't want to go deep because any injury should not be any gastric side injury. So I want to confirm whether it is fully done or not. So perioperative endoscopy will give the clear idea. I have to see whether it is a vagus nerve also. Usually, in my case, I used to separate the vagus from the esophagus, anterovagus, and then it crossed the vagus obliquely it crossed the esophagus obliquely from left side to right side. I thought of vagus, but after dissecting it, I could see it's only the fibrous tissue. So that is the esophageal mucosa. When the curve dissector, the tip of the curve dissector should be blunt, and it should not be a long jaw. Curve dissector, if you get it from stores, call stores, it is a regular one, and then long jaw curve dissector is there. We want a regular one, not a long jaw. Long jaw will be sharp tip. So I occlude the body of the stomach, and then I ask for a perioperative endoscopy. So one of my colleague or medical gastro colleague is doing the endoscopy now. This surgery done long back in COVID time, almost 6 years before it was done. Now you can see it was done, but I couldn't see any light. Only the esophagus side I could see the light. The stomach side I am not able to see the light. That means the muscle is there. So they are also telling that some resistance is there on the near the OG junction. So I decided that okay, I am not doing myotomy. I just remove only one layer. Still the muscle layer is there. So then now I started doing a myotomy. You can able to see the muscle. Previously it looked like a mucosa, smooth mucosa. So now I started doing a myotomy. So that's why perioperative endoscopy will be helpful. Always do in a difficult case and in a redo case. I don't do in a regular normal Hellers. If I feel, if I see the muscle very confidently, divide the muscle, mucosa bulb sprout out, then I don't do the endoscopy normally. Now you can see the muscle is there. The endoscopy gave me the confidence, so that I went one layer down, so I could able to see the mucosa. So I'm dividing the muscle fiber by fiber. I will be able to see the mucosa. So that is the esophageal wall. That is the mucosa of the esophagus. You can see some band like that is the muscle near the OG junction. That is the lower, actually circular muscle on the lower esophagus basically. The surgeon, previously operated surgeon, he start myotomy about a centimeter above from the OG junction, and then he did myotomy on the esophagus only, not on the OG junction. So now we can able to see the difference. It is a quite muscle is seen very nicely, and the mucosa is seen very nicely. And I pass the Riles tube, and then I am doing a leak test, air leak test. See, because previously I didn't do put a stomach, and then now we can able to see very clearly the bulged out, sprout out, bulged out mucosa. So I'm extending my myotomy, because always redo surgery should have around 3 centimeter myotomy on gastric side. So this is called extended gastric myotomy. So now everyone is convinced about the mucosa of esophagus, OG junction, and gastric side is exposed. And I'm checking for a crural approximation, because already patient had a hiatus hernia. So I started dissecting the lower esophagus. Usually, lower esophageal dissection, posterior dissection is not required in Heller's myotomy. Only the anterior dissection is required for myotomy. Posterior is no need. So I dissected. You can see the aorta. I keep my left hand between the aorta and the left pillar of right crest. So I am taking the right pillar of right crest. So both left pillar and right pillar is being approximated. This is one of the strongest suture, nylon suture. Otherwise called polyamide suture. I am taking another suture. This is a 1-0 polyamide suture with the 40 needle. So now I could see the tenting of esophagus after these two suture. Esophagus doesn't look straight. It is look at tenting on near the hiatus, near the crest. So what I did, I divide this second suture. So now you can see it is a straight normal lie of the esophagus is seen. So what I did, I started suturing anterior hiatus. So in hiatus approximation in Hellers is little controversial. Many people are not doing. They are telling that already dysphagia. Why are you making again dysphagia? But it is dysphagia is not because of the hiatus crest. Dysphagia is because of the muscle in a non-working circular muscle. That's why dysphagia. But hiatus to be corrected in Hellers cardiomyotomy if you feel it is a wide hiatus. It is need not like correct like GRD patients. Minimal correction is enough. I take the post fundus. It is not under tension, so it is lying freely. The fundus is lying on the right side. I'm taking a divided edge on the right side, and then I'm suturing it. Usually, I take the fundus. Yeah, you can see it's a right side. I do first 3 suture with 1 centimeter gap, so it will be 3 centimeter fundus wrap, posterior 2-pay fundoplication wrap on uh, after myotomy. This is the 2-0 polyester suture, Ethibond suture from Ethicon. Good suture thing, it comes with the 2 needles. So if you cut the suture in the center, you will have a good length of suture. So one suture is enough. With the 2 needle you can make it. If it is a single needle, half of the suture will be wasted. Otherwise you have to have a long thread. Without wasting thread means you have to keep a long thread inside. So that's why it is very advantageous, and needle is also very short needle. So it is a good one. So both side 3 suture is made, and this is the suture for suture fixation of the wrap to the right crest. You can see I am taking a good thickness of the right crest to prevent the transmigration of the wrap into the hiatus. Already hiatus is narrowed and it doesn't look like loose hiatus. The lie of the esophagus and stomach is good. I thought I want to, any fixation is required to the wrap to the left crest because already migrated, but there is not much gap. I am not doing that. I just check the wrap, left crest to the wrap. I am not doing it in this case. It should not produce any dysphagia. So good exposure of mucosa is seen, and this completes the laparoscopic redo Heller's cardiomyotomy in laparoscopic Heller's myotomy recurrence. Thank you so much.